Hello, everyone. My name is Jenna Groman, and I'm the Director of Global Communities of Practice here at Sabin Vaccine Institute. And it's my pleasure to welcome you to today's event, Social Media Listening for Improved Vaccine Acceptance. As we give everyone a moment to join, please share your name, your organization, and where you're joining from in the chat. During today's session, we encourage you to share questions for panelists using the Q&A button. And please also take advantage of the chat feature to ask follow-up questions and engage with others who are joining the call today. The Sabin Vaccine Institute and Bay Area Global Health Alliance are partnering to support the Alliance for Advancing Health Online, an initiative to help advance public understanding of how social media can be leveraged to improve the health of communities around the world. An Insights Dialogue is advancing this mission by curating research insights on a dedicated microsite, sharing peer-reviewed evidence, resources, tools, and more, hosting the VaxUp podcast series, as well as hosting live events such as this one in partnership with Boost, a global community where immunization professionals can connect, learn, and lead. And now I am very pleased to introduce you to our moderator for today's event, Nyok Nudlovu.
Thank you, Jenna. Welcome, everybody. It's the first time that we're seeing each other this year, and I'm glad to see some familiar faces and names in the audience. My name is Mwavizi Tandlovu. I'm the host of the Insights Dialogue conversations that are curated by Boost. And today we're talking about social media listening for improved vaccine acceptance. And I have a stellar panelist group for you, which I'll introduce shortly. I'll start with Angus, who is a senior social scientist at UNICEF. Angus is in Washington, DC right now, and in Kenya at the same time. He'll have to explain how he does that. Chia is the CEO and co-founder of 19 to 0, and Chia's in Canada. Mohashidi is a research analyst at Veritas Research in Sri Lanka. And finally, Maya is the program coordinator at the Minority Rights Group, and she's currently in Italy. Welcome to our panelists. Let's jump right into the conversation. I want to start by framing the conversation, and I'll ask Angus to help us with this one. Angus, what is social listening, and why is it an important tool to drive vaccine acceptance?
It's a really important question, I think, because different people understand this differently. When we initiated at UNICEF the Vaccine Demand Observatory collaboration, all of our work has been predicated on the basis of data equity. And by that we mean social listening is not just social media listening. There are many communities, probably half the world is not online, who are having conversations about vaccines that is not appearing on social media. So today we're focused on social media, and we're seeing increasingly, I mean, in Kenya, I'm in and out of a workshop in Kenya today. Facebook is an extremely important platform, but there are still many communities who are not online. And so we think it's important to always consider social listening as being the mechanisms you put in place to understand, of course, the misinformation, but also the information needs of people, their concerns, their questions, the information gaps that they have in relation to vaccines. Over.
Wonderful. I'd like to dig in a dip into that, and let me pull in Mohashidi to talk to us about how you've seen this play out in Sri Lanka. To understand COVID-19 vaccine confidence, uptake, and access, what have you specifically learned through your research, and what did you do? Let's start with what you did.
Thank you for your question, Nark, and thank you very much for having me here today. I'm from Verity Research, and Verity Research in collaboration with the Minority Rights group are implementing the Diversity Impact on Vaccine Equality program in Sri Lanka. And one aspect of the program was to monitor social media to track and understand conversations on COVID-19 vaccine uptake and access, as you mentioned, specifically across three ethnic groups, the majority Sinhalese community, the minority Tamil and Muslim communities, especially to understand the differences in sentiment by ethnicity. So to provide some context to understand our methodology for social media listening and our findings, Sri Lanka has a history of achieving high and equitable immunization coverage across the island. For instance, with the MMR and polio vaccines, we have achieved this. However, the pandemic brought its own issues, which affected Sri Lanka's socio-political landscape. At the beginning of the pandemic, members of the minority community, especially from the Muslim community, were blamed for being mass spreaders of the virus. They were also initially denied of burial rights for those who had died from COVID-19 as the government mandated cremations. And then beginning of last year, with the spread of the Delta variant in India, the entire country faced a shortage of vaccines. And like elsewhere in the world, health-based misinformation was rampant. In fact, Verity Research's own fact-checking platform, factcheck.lk, we've fact-checked multiple government ministers stating false claims regarding COVID vaccine and the vaccination process in the public domain. So with all of this in mind, So today we see Sri Lanka having vaccinated over 60% of the total population. And despite having secured stocks of COVID-19 vaccines, misinformation-fueled hesitancy is one of the key issues that we face. And currently the country is also experiencing a very low turnout to receive the booster doses, despite the spread of the Omicron variant currently. So given this context, we used social media listening tools, specifically Brandwatch and CrowdTangle, to extract posts that were shared by public pages on Facebook and on Twitter. So on Facebook, we extracted the posts with the most comments, and then we also extracted tweets and replies to tweets. With the main aim behind this was that we believe that this is where we will be capturing online conversations among social media users. So we use the names of the social media users and the languages they used in the comments as markers to identify their ethnicity. And then we manually coded over 1,000 comments and tweets to assess each of them for confidence towards vaccines, issues related to vaccine access, distrust in authorities that were expressed by each of these users. So if I have to summarize 3 key findings from our social media exercise, what we learned was that concerns relating to COVID-19 vaccine confidence is what dominated conversations online. Specifically, low to no confidence levels in vaccines were much more prevalent among Muslim and Tamil social media users from the minority communities, whereas the majority ethnic group, the Sinhalese social media users, displayed higher level of confidence towards the vaccines. And also of those who did display low levels of confidence, their main concern was regarding vaccine safety. And in particular, Muslim social media users expressed the most concern over safety. Now, these issues related to safety were mainly related to the rapid development of the vaccine, the fear of side effects, and also what the vaccine itself comprised of. And thirdly, one of the most also important findings was that across the ethnic groups, there was a selective preference or confidence in certain brands of COVID-19 vaccine. Particularly, they showed more confidence in Pfizer and Moderna than in the Sinopharm vaccine, which is also the vaccine that was widely administered in Sri Lanka. And this lower confidence in the Sinopharm vaccine was mainly attributed due to fears over the quality of the Chinese manufactured vaccine, Sinopharm having a low rate of approval for global travel at the time we were monitoring, and also China's growing economic and political presence in Sri Lanka, which adversely impacted the level of confidence in the vaccine among social media users. So the importance of these findings is that it can definitely inform and help stakeholders who are involved in the vaccination process to design effective communication strategies that can be targeted in improving COVID-19 vaccine confidence and uptake. And in fact, Verity Media is currently disseminating an online campaign to this extent, especially in terms of debunking COVID-19 related health-based misconceptions in order to promote vaccine uptake and acceptance in the country. So this is just merely a brief insight into the work that we've done in this project, but if anyone is interested in the detailed findings, the link is included in the chat box, and I'll be happy to take any questions during the Q&A.
I was just about to ask if there is something that I can read about this study and this work that you've done, because it sounds quite complicated, complex. There are layers to this that are not just about hesitancy, right? You've talked about trust, you've talked about religion and divisions between people. I'd love to sink my teeth into that report. We'll have it in the show notes as well. And the folks in the audience will also get to ask you some questions in the tail end of this conversation. So thank you, Mahashidi. Let me turn to Gia for a second. And Gia, 1920 used a different approach to social listening. Tell us about how you used natural language processing to analyze vaccine attitudes in Canada, and maybe a bit about 1920, what you guys do as well.
Yeah, for sure. Everyone, I'm Gia. I'm a public health doctor based in Canada. 1920, I mean, if you just go to the next slide or 2 slides down, and 2 more. Yeah, sorry about that. Really is a not-for-profit coalition that formed about 1.5 years ago, so before the vaccine was available, to really address questions of vaccine hesitancy, to build vaccine confidence. And I think to one of Angus' earlier points, our approach really was broader than social media and natural language processing, but I will focus on that. And so, I mean, we have been gathering data through traditional surveys. We've been surveying a sample of 1,500 Canadians every week for about 70 weeks. We've been working a ton with different community groups, ranging from certain segments that may have reason to have less confidence in the vaccine, certain racialized populations, Indigenous populations. And so think of that as, focus groups, interviews, just, on the ground listening. But, I think in spite of doing those things, we felt that it was important to really understand more comprehensively what was happening in the social media space. And, we've worked with lots of organizations that I think take qualitative approaches to social media listening. And that's sort of like going online and like following some influential accounts and seeing what's happening. But instead of that, what we really decided to do was, if you go to the next slide, use some artificial intelligence-based approaches to try to analyze everything that was happening in the North American social media discourse. And so what does that basically mean? Well, I use Twitter as an example. So from November of 2020 to January, to this year, basically, we basically got all of the Twitter data and metadata. So that includes things like not just what people are saying, but also who they're liking and sort of who they're sort of reposting. And we applied natural language processing to basically summarize all of the content, right? And so what that means is we could basically, say that, there were this 100 million tweets that were pro-vaccine, this 100 million tweets that were anti-vaccine. Predominant themes were themes around, let's say, vaccine safety at a particular time versus themes around mistrust in government and institutions and elites. And so that, I think, allowed for just a more comprehensive picture of what was happening. The other thing, if you that we were able to do, and if you go to the next slide, was do a social network analysis, which basically allowed us to sort of organize, different clusters of conversations, because I think there is a sense, an accurate sense, that there are certain groups. If you're a doctor like me, you're probably talking to people who are into vaccines, and we may not be communicating very much with people who are not as into vaccines. And so I can go into some more detail about that, but is basically that's a high level summary. Sorry, we're jumping all over the place here of sort of what we did. Should I keep presenting?
Yeah. Go ahead.
Okay. Yeah. So maybe if you just go back to the slide before, just at a high level, this was sort of an example of our sort of sentiment analysis. And so we could basically trend overall sentiment, positive or negative, over time, and then classify themes actually over time. And so if you look at the sort of tall blue line, the predominant theme was actually around mistrust in institutions and elites. And so that's saying, I don't trust the government of Canada, I don't trust Pfizer, et cetera, et cetera. But an interesting finding during April in Canada, the sort of vaccines we had were the mRNA vaccines and the AstraZeneca vaccine, was that there were some concerns around safety around the AstraZeneca vaccine when it was sort of released. And so we saw this huge spike right here in April when that vaccine was released around how it might cause certain clotting events. And because we were able to sort of rapidly identify the signal around safety, we could basically tell both the sort of our general sort of marketing teams as well as our community groups that we should pay more attention to sort of the safety signal that had arisen on AstraZeneca, and to message against that, as opposed to sort of generally message around how important it is to trust public health. And that's an example of how you can sort of quantify what was happening over time. If you go to the next slide, and this is an example of the social network analysis. I'm running out of time here. Sorry. It's, on the left here, you see this sort of anti-vaccine cluster and a pro-vaccine cluster. And earlier on in the pandemic, we saw a lot of our conservative leaders, sort of right-wing political folks, sitting in the middle of the pro-vaccine or the anti-vaccine clusters. And, these people were not full-on anti-vaxxers, but they were, they were saying things like the vaccine rollout sucks, or our prime minister sucks. And they were actually being used by anti-vaccine folks to really say that, we didn't believe in vaccination. And, again, one thing 9-0 tries to be is very intervention focused. And so over time, a thing we were able to do was talk to some of these people and say, hey, if you aren't more unabashedly pro-vaccine, a lot of vaccine hesitant folks will go to you and say, I'm listening to you and saying we shouldn't get the vaccine. And so we're able to shift some of those influential political leaders into sort of the pro-vaccine camp. And so those are just two examples of how we could use, rapid analysis of data to inform certain interventions. And I've gone on too long, so sorry about that.
Thanks, Gia. This is very useful. And this presentation is available to the folks who want to check it out after the show. And speaking of data, Angus, you've done a lot of work exploring how to use social listening data to improve interventions. What have you learned, and what resources are available to help expand the use of available social listening data?
Great question. Just to step back a minute, to be able to do what you've discussed, to be able to inform intervention testing and design and testing, in particular, rapid iterative manner, which is possible on social media platforms, we first have to understand what it is that we need to develop. And part of that comes by viewing people's positions through a behavioral and social science lens. And we've got a huge body of behavioral and social science data now that gives us a good idea about what might be driving people's decisions. But another part of this comes from social listening and being able to understand the questions and concerns, the information needs that people have. And that work comes from exactly what you've just heard from Gia. And what the Vaccination Demand Observatory is aiming to do is to basically take the kind of approaches and work that you've heard in the last from both Maushadi and in particular from Gia, and implement that, integrate that into routine programs. We think this should be part of programming over the very long term. It's been a gap that we've had for decades. We've been shadowed by misinformation forever in vaccination programs. So the observatory, which is a UNICEF initiative, and I'll go quickly through my slides because I want to get to the most important point about how do we develop and test content. But the observatory, and if we can just go to the next slide, is a collaboration led by UNICEF, but a collaboration with the Yale Institute for Global Health, a center of global center of excellence in the behavioral determinants of uptake and acceptance, and the public good projects who've been doing social listening for vaccination and informing vaccination programs across the US for over 3 years. We've already talked about the importance of data equity. The other important thing about social listening, and that's what we're getting to here, is it's got to be coupled to action, right? There's no point in doing it if you're not able to extract from it the insights and the actionable recommendations that then inform what you do in the field. So if we go to the next slide, we've got a series within the package, and I've just literally come out of a workshop in Kenya where we've got many partners around the table, where we're mapping out the ecosystem, the communications ecosystem within Kenya, who's doing what in terms of social listening, that first step, the strategy setting workshop. But then we bring in a pretty sophisticated social listening platform that will allow countries to do the kind of work, a lot of the work that you've heard from Gia already. Social network analysis is maybe a bit too much, but the system has the algorithms, the NLP, the natural language processing, to allow it to tease out the important themes, the key, the sentiment behind the content that is being teased out. So to really extract the signal from the noise, and to do that in a systematic way and at a kind of an operational way, at a programmatic level. Then we've got a capacity building package, and most importantly, to your question, support for developing localized digital content. Now, if we can quickly go to the next slide, in addition to, so the key here is you've got to be able to take the data and produce intelligence or insights, right? So it's wonderful, the Talkwalker and Meltwater and all these wonderful dashboards, they're great. But if you can't squeeze the juice out of that lemon and come up with real insights that help the people in the field, the communications people, the risk communication, community engagement people, help them do what they need to do to respond to a specific rumor or not, to provide the information that people are asking for, to address people's specific concerns. If you can't do that, then it's useless. And so the system we're setting up is very much focused on this, and that means having the people in front of the dashboards. You can go to the video website. If we can go to the next slide, you can go to the video website right now. In addition to a live system using a system called Signal Labs that is like the Talkwalkers, etc. We are starting to stop the misinformation alerts that our analysts are producing on a daily basis at a global level for both COVID-19, routine immunization, and polio. And as we're going from country to country, we've already been implementing this in. We've already been in 5 countries in the last 3 weeks. We've got dozens of countries lined up. We're going to be feeding this database with the misinformation alerts, in a sense, that the intelligence, right, the insights, not just what we're hearing, not just the tweets and the Facebook posts. And so, do go and have a look. You've just got the link in the chat. But let's go to your question. And if we go to the next slide, please. So you've asked about assets and what's available. On the video website, you have both the vaccine misinformation management field guide available in 5 languages. We'll be adding additional languages to that. You've got a messaging guide that we've developed as well, webinars that we did with Sabin a few years ago that some of you may have seen, and we're developing an online training. But let's get to the messaging, because I've only got 1 minute. I just got the slap on the wrist there. I won't talk about inoculating people against misinformation today, but there's some pretty exciting stuff going on. We can set up national vaccination systems against to vaccinate people against misinformation. So the lab that we've set up, and we are working to develop this capacity at a country level, looks, as I touched upon, at what are we hearing through the social listening? What are the behavioral insights tell us in terms of how we might respond to that? But also what is being shared online, right? Social media, it is driving an attention economy. It's all about getting people's attention, getting them to open something, and then getting them to share it, right? We all know this. And so if you don't produce content that captures people's attention and that is eminently shareable, then you're wasting your time. You're not even playing in the third division, let alone, being up there with the big teams. What we're doing is passing, we're using tools that big retail companies, imagine the Cokes and the Nikes and the BMWs use, to understand what is being shared online where we need to be. This is primarily happening on Facebook at the moment. What are the colors? What are the typographies? What's the kind of assets that people are using? Is it videos? Is it photographs, etc.? And we develop the content, and then we rapid A/B test it. We've put content over 5 countries in front of 100 million people, right? We test it for format, for message, for messenger, for tone, for framing of the message, depending on what we think is going to be important. And we test it over and over so that we get to things that we think are going to be get people's attention, are going to obviously work in terms of the behavioral objectives that we have, and that they're likely to share. And what we're finding is pretty spectacular effects, as good as what any Nike marketing manager would be happy with in terms of effect sizes. We're finding that it has to be contextual, right? Contextual. There's no magic bullet. And we're also finding that some of the insights we've developed over the last couple of years, for example, moral values, are really holding up in some countries. We have liberty-based framing, and that is working in Ukraine very, very well. But what works in Ukraine doesn't work in Pakistan, doesn't work in India. Over.
Yeah. Thanks for that, Angus. I'm glad you brought up context, because one challenge with social listening is ensuring that the data gathered is representative, right, of the full community. So I want to ask Mohashidi, how can offline strategies such as surveys and focus groups be used in combination with social media listening to ensure the findings are relevant to all of your target audiences? What did you find in Sri Lanka? What lessons can we learn there?
Yeah, great question, actually. So we've mentioned this on our report as well. Getting an unbiased representative sample through social media listening was definitely a challenge. And for this reason, Verity Research, along with our survey partner, Vanguard, we conducted an island-wide survey among 2,400 respondents who were 18 years and older. And given the scope of our study, we focused on achieving a sample that was representative of 3 ethnic groups, the Sinhalese, Tamil, and the Muslim groups. So this did mean that we had to adopt a purposive sampling framework, and we also oversampled the members from the minority communities to achieve equal proportions of the groups for the districts surveyed. So that was the way in which we went about with that. And if it's possible, I would like to speak a little bit of survey findings, which were then used to triangulate these social media findings. And it definitely gave us a sounder understanding of ground level sentiment. And one of the key findings that we found was that in terms of hesitancy and resistance to COVID-19 vaccines, it exists in small pockets. In fact, 96% of our respondents had received at least 1 dose of the vaccine, which left us with 4%, which is roughly around 100 respondents who remained unvaccinated at the time the survey was conducted, which was in December 2021 to 1st January 2022. And what from this unvaccinated group, we learned that it was the minority members who were 3 times more likely to remain unvaccinated. And of these respondents, they were more likely to believe in misconceptions that related to reproductive disbenefits from taking the vaccine, and also political conspiracies that surround the virus and the vaccination process, which did have a direct contribution towards them not taking the vaccine. And something that Gia also touched in terms of mistrust in institutions. Actually, what's interesting in Sri Lanka's context is that what we noticed was that not trust, I wouldn't use the word trust, but confidence in individuals were far lower. And by individuals, I'm referring to the president of the country, the Minister of Health, and local and parliamentarians were far less in comparison to the confidence that the respondents had towards the government healthcare sector. So this included public health inspectors, the medical officers of the area for each of the, at a district level, and even government doctors and nurses. So we did incorporate all of these findings when we were designing our online campaign as well, because it helped us understand who we should be using in terms of promoting these conversations, in terms of trying to promote vaccine confidence among these small pockets of individuals who still remain unvaccinated. So our offline strategy definitely helped ensure that the findings were relevant to our target audience, and also increased our understanding on how better to intervene these pockets of unvaccinated individuals. I hope that answers it.
Yeah, yeah. And if I'm in the audience, what I'm hearing is social listening gathers very context-specific data, but that there are also similar approaches that can be applied across countries. So I wanna bring Gia in here, and Maya, but let me start with Gia. How can the approaches that you've described today be applied to other countries or communities? Gia and then Maya.
Yeah, so I totally agree with the fact that context is super important, but you're also right that there are sort of things that I think can cut across. And so, I mean, for example, part of what we do, like the things that I think that are very contextual are things like relationship building, creating trust, working with communities to build that trust. But let's say with the work that we do, and I think similar to work the Angus does, right? Like we use algorithms to really just summarize large amounts of data. And I think we could apply these same algorithms with a bit of tweaking to other jurisdictions, to other countries and other languages. In fact, one of our next projects is actually to do this. And I think that sort of that piece where we can use the same approach to at least summarize everything, hopefully in a way that's useful and actionable, is something that can be applied outside of Canada, outside of, higher income countries. I also think that sort of over time, you begin to see certain common drivers of vaccine hesitancy. I mean, certainly what we've been seeing, and I suspect at least this is similar across the world, is three factors really that affect vaccine uptake. One is this big thing called trust, which very, very contextual. Another is concern around COVID. And so, the more worried you are about COVID or a particular disease, the more likely you are to do something about the disease. If you think it's a minor cold, you probably won't care. If you think it'll land you in the ICU, you probably will care. And then the last piece being sort of a access writ large, which includes, things like just how much vaccine is accessible, but also, one's ability to, take time off work to actually get the vaccine, or take time off work to see a physician or a healthcare provider. And I think some of those themes, are broadly applicable, probably in different proportions. And so there's an example of an approach, the NLP, as well as some of the findings that may be more generalizable and are not as context specific.
Thanks, Gia. Maya, if you'd like to expound on some of what Mohashadi has spoken to in Sri Lanka, but in other countries as well that you work in, what can we learn from that?
Thank you. Hello, everyone. And to answer your question, I should probably go back to the way we started researching the through social media listening and monitoring tools and CrowdTangle and BrandWatch. These are the two platforms that were the most important sources in our research. And in the beginning, we were looking in particular on the posts that are shared under the vaccine or specific communities and vaccinations. But we noticed that the posts do not really provide the information that we're looking for in terms of to address the questions of confidence, access to vaccination, and distrust. And then when Verta Research developed the methodology looking actually into the comments, it was the moment that we understood that we should actually apply this particular methodology all across the three countries in Algeria, Kenya, and Pakistan, because I don't know for what reason, maybe it's a cultural aspect, maybe it's an individualistic aspect, but people do not really share their sentiments on vaccination in the platforms and social media so openly as they do in the comments. So this kind of approach was a working approach in all other countries that are part of our research. However, I should mention that despite of the fact that it's a working methodology, in a sense that we can identify ethnicity through the names or religion, through the names or using the language as a disaggregated tool, there are certain limitations, in particular in Algeria, Kenya, and Pakistan, because the minority communities that we're targeting there, they are mostly either in rural communities where there's very limited access to internet, which means keeping in mind that these are minority communities and the proportion of them living in these countries is much lower than the general community, and given that their access to internet is also limited, it's a certain limitation that gives us less information from the targeted communities, ethnic communities or indigenous communities. And when we talk about the methodology applying of language and ethnicity as a disaggregated tool to target the ethnic communities in Algeria, there are other limitations in the sense that local indigenous community Amazigh in Algeria is very hard to identify by language or by names because they're mixed up. Many of them do speak French, they do speak Arabic, and they use these languages in social media, and their names can also be either Arab or Amazigh. So there is a certain kind of margin of error to identify a specific targeted community here. So we know that some of them we were not able to identify. But overall, the methodology is quite useful and we've been very successful in this sense. But we also need, given the circumstances, given the context in every country, we needed to also be creative and expand in certain areas, such as while we're focusing on Facebook findings or Twitter findings, let's say in Algeria, we're also looking at specific regional platforms that are common in these communities. I would give an example of a region, Hardaya, in Algeria, where there's a big population of Amazigh, and they have their own council that has a platform on providing information in local indigenous language, Amazigh. And they do have their website, they do have Facebook page, but they also have YouTube and Instagram. And we do see that the people are commenting there freely. And we know for sure that this is Amazigh community. So we're using this also as additional methodology towards the existing methodology developed by Verity Research to supplement the findings from the Facebook and Twitter.
And Maya, what you're speaking to here is important. A lot of social listening data is being gathered by many different organizations to understand how best to drive acceptance and demand, vaccine acceptance and demand. How can we as a community, the people on this call and who are listening to this recording, how can we ensure that the actionable recommendations are shared to amplify impact?
I think there are certain things that we need to into consideration when we want to do the messaging or reaching out to the communities to spread information about the vaccines. We need to take into consideration who are the figures in these communities that are leaders or have certain kind of authority to get in touch with them and partner with them to be able to reach out to the communities, because these particular communities, we talk specifically about minorities, ethnic minorities or religious minorities, they trust these people, and it means that partnering with them, we will certainly have a platform where people will hear the information that we want to spread. This is one way to do that. Another way is that we need to make sure that we're reaching out to this community through the platforms that are accessible to them. A very important aspect of this, that it's, as Angus mentioned, that a lot of people do not have access to internet. And I also mentioned that our specific targeted communities have very limited access to internet. It means that we need to go beyond online services, beyond the digital world, and reach out to these communities through the means that they're using in their daily lives, such as radio, TV, or even being present on ground and talk to them about vaccinations. And speaking of access to information, we also need to make sure that the information that we spread is accessible in the language of these communities. For example, in Algeria, the Amazigh community, although they do speak French and Arabic, the information that is spread in Tamazight is very limited. In our findings, we found that the main source of information on vaccinations, COVID in Algeria is a news platform that doesn't spread information in Tamazight. And it means that this limits the access to information to be able to tackle misinformation. It makes the minority communities more vulnerable to myth and conspiracy theories when they don't have access to the information in their language that they speak and understand. But another thing, I want to go back to the point that partnering with the leaders or people who have some kind of authority, it's also an aspect of partnering or working alongside the representatives of healthcare system, because they also have, in many cases, authority in the communities. People trust them. Not everyone, of course, but there is certain trust in these communities.
Trust, partnerships, very important. Thank you for that, Maya. I want to shift gears a bit here. I have so many questions still, but I know there are a bunch of questions from the audience, and we'll turn to the audience now. There are a bunch of questions. Jenna, how are we going to do this? I'll read out a few that I'm seeing. There's one for Angus, particularly that I'd like Angus to respond to. It's from Yakub. And Yakub asks, how can we improve vaccine acceptance amongst the communities who are not using any type of social media? Angus?
I'm not sure that the approaches are that different. It's just the way that we actually finally communicate with people. So when we're communicating and trying to reach and influence people on social media, we know that we'll put content out there and that will sit there, and we want to attract their attention and share, as I touched upon. People who are offline, in the work that I've just been hearing is ongoing in Kenya, we have extensive networks of people in communities, talking to people in communities, working through religious leaders to communicate with communities. It's the same thing. We have to back up to what does the behavioral and social science tell us is likely to work. We have to evaluate the misinformation and decide whether or not we're going to address a rumor, because addressing rumors can also give the rumor oxygen, right? We have to understand the best way to frame a response to somebody's concern. The advantage of being able to do it offline is that we can bring in a human element. We get our truths from the people we consider to be trustworthy. And those are people that we think we understand are expert, really understand what they're talking about, but also who have our best interests at heart. And so what we are able to do in offline engagement, and what we should be doing, is training those people who are doing that engagement, not just in what they're going to say to people or what they're going to share with people, but in how they're going to do that. So, I've developed a training course for health professionals that's being rolled out across the world that spends all the time talking about the how and not the what. But I think there are some core things that are the same, and there are some things that we need to apply whether we're online or offline. But it's a great question, because we have to be viewing the communities in a country, both in terms of the geographical communities and also those virtual communities, right? And thinking about what are the concerns that each of them have, and how do we reach them? Over.
Yeah. Thanks for that, Angus. And there are a lot of questions directed at you about inexpensive resources for organizations that have limited resources. How can they get to those training sessions? I'm sure you can share some of those, with them, links and so on, that we can share with our audience.
They've been shared. Some of them have been shared in the chat. A lot is consolidated on the video website. You have the link to that. We have a 10-module training coming up on this work that will be open to everybody. And I think, to go back to your question, how can the folks on this call, how can we work together to do this better? I think this is one of the things. We can all up our ability, our skills, our knowledge in this work, which means that, in our day-to-day job, we can be doing things better and contributing to social listening mechanisms and feedback in our countries. we can all be reporting misinformation and thinking about how we would address it, etc. But I do think that this has to become a standard skill, right, for the folks who are on the call, for the people in the Boost community. This is where you need to start developing, this is the next space that you need to start developing your skills. Over.
Excellent. And speaking of Boost community members, there's Sohini here, and Sohini is asking all the panelists, and she asks, I noticed many fence sitters became vocal in posts against the need for COVID-19 vaccines when things like vaccine passes started getting introduced. Did this kind of insight come up for any of the panelists in their work, research? And Sohini, thanks for that question. Sohini from India. Gia, you want to take that one first?
Yeah, it's really interesting. I helped make a lot of the mandates in our country, and I think we did see, and again, whether or not you put in a mandate, I think is highly contextual because there can be a lot of blowback. But really what we saw, and I think it was quite common across a lot of countries that did this, was higher uptake among, before these mandates. I think a lot of younger people weren't getting vaccinated as much as older people, and I think actually that speaks to not an issue of lack of trust in the vaccine so much as people just couldn't be bothered to get the vaccine. In the same way that I probably should see my doctor, but I haven't in a few years because I just can't be bothered. And I think what the mandates really did was it made it such that people would need to, it gave them a nudge to do something that they probably would have done at some point in time, so that they could do things like go to a restaurant or hop on a flight. And so that is sort of something that, we saw. I mean, certainly there was a lot of controversy around them, but I think they sort of did achieve that goal. And I think this speaks to some of the other sort of audience questions around like what really are the drivers of vaccine uptake. And I think there are a small number of people who are really, really dead set against vaccines. They have microchips, whatever, conspiratorial thinking. But I think for a lot of people, it's a bit more complex and nuanced than that. I mean, I don't think your average 25-year-old is more vaccine hesitant than your average 80-year-old. But without that nudge, people weren't getting vaccinated in the same numbers, the younger than the older. And so that was a really interesting phenomenon.
Maya, Jacqueline has a question for you. A lot of focus on barriers, she says. Are we paying enough attention to what is driving people to get vaccinated?
Are we paying enough attention to get? Can you repeat the question, please?
Are we paying enough attention on what is driving people to get vaccinated?
Well, if we're talking about minority communities, we know historically they have lower rates of vaccinations for various reasons. Not having access to health facilities because most of them live in remote locations, or for religious reasons, they refuse to get vaccinated. Or as I mentioned, the access to information makes it difficult for them to make a decision to information. So there's some kind of understanding why it happens, but I wouldn't say that it's there's a clear answer to that, because it depends also on the context why people from minority communities, in our case, refuse to get vaccinated, or the level of confidence in vaccination is much lower than in general communities. But what I want to say is that I actually want to go back to the question that was mentioned earlier and say that we noticed that throughout the timeline, when certain kind of vaccines were introduced in a specific country, the number of conversations around the vaccinations would increase, usually specifically within that time. And a lot of the time, the conversation would be more negative than positive. This was the case in Algeria. This was the case in Kenya as well. And I hope I answered the question. Thank you.
And thanks, Maya. And let me pose this question to Moashidi. You spoke a lot about the Muslim community and the Tamil community in Sri Lanka, the issues around trust. And Yakub asks, how can we create the trust of communities for the acceptance of vaccines from social media? I suppose is referring to some of the people that you dealt with.
Yeah. So this was something that internally we brainstormed as well. So this is where our social media and survey findings really came in handy, because we were able to isolate individuals that we could use in order to promote vaccine acceptance. So as I mentioned, people from or actors from the government health sector were seen, sorry, let me just rephrase that. Respondents from the government health, respondents of the survey showed higher confidence towards actors from the government health sector. And so this is something that we included in our online campaign as well. So we used existing videos because currently the government also is carrying out a massive promotional campaign where a lot of doctors and health officials are getting a lot of screen time where they are debunking myths and misconceptions surrounding COVID-19 vaccines. So we tapped into these existing individuals that people are familiar with. We specifically got doctors who were speaking in the local languages, the Tamil and Sinhala languages, and featured these in the videos that we are currently promoting. The campaign is ongoing, so we will see results over time. But this is one way in which we can create trust, is by making the face or the face of the particular video and the one who is promoting the message, someone that that particular community can resonate with and has higher confidence in. I hope that answers the question.
It does. Thank you, Mahashadi. And we have enough time for just one more question, and I'll pose this to Angus and Gia, 1 minute each. Esther asks, just curious whether you're working with government partners, such as ministries of health, to share the social listening insights. Would you be curious if the government has been receptive to leveraging these insights in risk communication efforts? Angus, then Gia.
Sure. So we've been in as I mentioned, 5 countries in the last 3 weeks. We've got maybe a dozen countries lined up. In almost every country, at one level or another, we're working with the Ministry of Health. We see different levels of social listening mechanisms in place. What we do see is that they're grossly under-resourced. This is an area that needs resourcing. What we see is that they're often not yet successfully coordinating with all of the other partners who may be doing social listening online, offline, or providing, community feedback, et cetera, So there's a level of coordination. But in almost every country that we're going into, depending on we see different levels of implementation, but the Ministry of Health is involved. They have to be involved, but I think the key here is that while it has to be led by the Ministry of Health so that it becomes embedded within the program, but you have to also coordinate all of the other partners who can enrich the program over.
Gia, 30 seconds.
Yeah, very similar. Work with ministries of health. I think they're pretty bad at this, actually. Like, it's pretty impressively bad, and there's different degrees of receptivity. But I do think, I'm going to say exactly what Angus said. It is quite important that, it becomes embedded in what they do, because they stick and they last. And I mean, not only they tend to be not so good at like the social media listening part, their ability to coordinate is also kind of poor. I think even in a place like Canada, which is pretty well resourced. And so lots of work to do still.
Excellent. Well, I'll have to put a pin in it here. This has been a great conversation. Thank you to our amazing panelists for making the time to talk to us. And the conversation continues. I'm going to hand it over to Jenna to let us know where to find our panelists, where to find some of the answers to the questions that we didn't get to. Jenna, over to you.
Thank you. And I just want to echo the thanks to all of the panelists today. This was truly a fantastic conversation, and really excited to see where we can move the pin forward together on this. To echo what was just shared, this is not the end of the conversation. This is really just the start. We were excited to hear about the research and have this discussion and bring in some of the questions we've had, think about how we could work more collaboratively in this space as well, and make sure that all of this work and all of the insights that are being learned can drive forward action. So in terms of what to do next, that brings us to our point here. First, we want to thank you all for joining today. Please come and visit insightsdialogue.org. You can explore more resources. You can learn more about these studies when complete, and some of the tools that Angus shared are on those. But also, we hope you'll join the Insights Dialogue group in the Boost community. That will help you stay connected. We will be sharing more responses to the questions we didn't get to today in that group. And you'll also stay informed of upcoming events and learn about other opportunities that we have moving forward. And please also, before you leave today, please take a moment to take our post-webinar survey as well. We'd love to have your feedback, and so that we can use that to help shape our future offerings in this series and think about how we want to drive our work forward. So again, just a huge thank you to all of our panelists today for sharing your insights, sharing your research, sharing your learnings. We were so thankful to learn from you. And thank you to everyone for attending and giving us a little bit of your time today. And we look forward to speaking with you again soon. Have a good rest of your day. Bye-bye.